Dr. Horn, you touched earlier on the importance that there's a pathologist who's part of these meetings, and they often put up slides that looks like wallpaper to the rest of us. We're not used to interpreting what these cell types mean, and we have to take their word that these cells are either aggressive tumour cells or not. How important is it, do you think, to have the pathologist there presenting what they see of the tumour under the microscope?
So I think it's very important. I think the pathologist gives us an idea in terms of staging the cancer. And to be honest, the more wallpaper you see, the more familiar it becomes. So sometimes the pathologist can put a slide up there and I almost know what it is. But having our pathologist right there, and you know, it really just makes them more part of our team. So that when you are calling them with questions, they know who you are, we know who you're talking to. And
so they're not just the invisible man behind the desk in the pathology lab.
Exactly. And I think that that really makes a big difference in terms of communication, because we're all there to treat the patients.
Now we know that in medicine, in managing cancer in particular, there's a huge human factor to it. The pathologist is a human, it's their interpretation of what the cells look like under the microscope. Dr. Sandler, human being, looking at imaging, giving your opinion. We all weigh into our own opinions on how cancer should be treated, although more and more we try and adhere to national guidelines. The pathologist is a human being. They're looking at these tissues under the microscope. Two questions I have for both of you. Number one, at Vanderbilt, is the pathologist who's looking at the tissue, is that somebody who's specialising in lung cancer, or are they pathologists that look at all tissue? And is that important? And number two, where does these new molecular markers in tissue come into the report that these pathologists provide clinicians like yourself? How important are these molecular markers in determining how to manage the patient who's sat right in front of you?
Most of our pathologists are specific to one particular disease site or several disease sites. You know, I've gotten to know our pathologists very well. I trust them implicitly. They're fantastic. To get to your question about how important are the molecular markers, I think that at this point it is absolutely essential for systemic therapy. It's less critical, at least at this juncture in time, for radiation therapy, but in terms of what can we expect the patient to get with systemic therapy, I would say that that's absolutely essential. And I'll let Dr. Horn talk more about that.
So it's important for systemic therapy in advanced stage disease. So right now, for a patient with stage 4 disease, what our pathologists will let us know is, one, what the diagnosis is, so is it small cell or non-small cell? And as soon as we know it's non-small cell, because that's really where molecular testing is important, they'll tell us on the pathology report the tumor has been sent for molecular testing and PD-L1 staining. They'll also tell us in their report there's insufficient tissue for molecular testing, because that immediately triggers us calling the radiologist or the pulmonologist and saying, hey, we need more tissue. Once the molecular testing is back, that's when we'll make the decisions in terms of systemic therapy in patients with advanced stage disease. In patients with early stage disease, molecular testing is not necessarily standard of care at all institutions. And partly that's because right now it's not actionable. So for example, if you have an EGFR mutation, or if you have an ALK rearrangement or a ROS1 fusion, and you have early stage disease, chemotherapy is still standard of care. A targeted therapy is not. There is a large intergroup study across the United States and abroad that's looking at adjuvant therapy with EGFR inhibitors and ALK inhibitors, either in lieu of systemic therapy or following systemic chemotherapy in patients with early stage disease. So at our institution, anyone with early stage disease is signed up for testing in the context of the clinical trial, but everyone with advanced stage disease gets molecular testing as reflex routine care.
So that's just part of the overall analysis of the tissue right from the beginning.
It is, and the nice thing is by having it as reflex testing is, as a medical oncologist, I don't always have to request it. So, but by the time the patient is a week into their diagnosis and set up to, I'm seeing them a week later, that information is almost there. And so a patient doesn't have to wait another 2 to 3 weeks after a visit before we can sit down and have that intelligent, important discussion about here's what your treatment is going to be.
Do you think, I know none of you are pathologists, but do you think that these molecular markers take away some of the subjective interpretation about different tumour types under the microscope, where with these markers we can actually clearly say these kind of tumours will light up with these markers, and therefore takes away the human interpretation, if you will? Or is it a bit more complicated than that?
So I don't think it takes away the human factor, because the pathologist can look and say, first histology, but they'll often say, well, it's TTF1 negative, and if your tumor is TTF1 negative, we know it's unlikely to have an EGFR mutation, for example. So sometimes they can sort of figure out what the molecular markers may be. The other thing that we know by having a pathologist who specializes in thoracic cancers, they sometimes change the diagnosis from outside slides. It is not unusual that a patient comes for a second opinion and our pathologists have a different diagnosis, which really leads down a different treatment algorithm for patients.